it's a great segue because, I mean, clearly I think we identified that this is a very tough group of patients. You know, as I try to instruct my fellows on acute leukemia, I really try to take the words good risk really out of their, you know, their lexicon. You know, I think it can be sometimes confusing for patients. I think it can be a bit misleading. You know, I think as I look at AML, it's really a question of poor risk or horrible risk. You know, when you really look at the comparison to other illnesses, it's a very, very serious illness that we clearly have made great strides, you know, but it's still a very catastrophic illness that patients still are very fortunate if they're able to overcome their disease. So clearly the focus is strongly on new therapies. You know, how can we impact them further? Why don't we start, Elias? You brought up the issue of ABT-199 as one promising agent. Let's have a bit of a discussion around some of the promising agents in this space. Why don't you tell us a little bit about that one and where that might play a role?
Well, new drugs, we're at ASH, and there's plenty of new drugs, a plethora of new agents. Pick and choose and do the combination you want. Just to remind everybody that the FDA has not approved any drug in the last 20 years for AML at least, except for Mylotarg that was withdrawn from the market. So we really need treatment for these patients. Plenty of agents, among them you mentioned the venetoclax or ABT-199. A lot of noise, it induced MRD negativity in CLL, for example. In AML, it's a BCL2 inhibitor and apoptotic, and all these paths are being targeted. The drug was used as a single agent, and we had a combination adding ABT-199 to decitabine. It's a really good combination. You can induce responses, 70% response rate and higher in unfit patient newly diagnosed, better than decitabine alone, by the way. We induce MRD negativity. I'm not sure about duration of response. We don't have the data yet, and data is not so mature. But at least we can have a good response, achieving a deeper response, and go for transplant. If you want to go for transplant, send the best population you have for transplantation if they are fit. If not, at least have a good response and maintain it. It may go for induction with combination and move forward to a maintenance program with decitabine, or we're seeing new data coming from oral formulation of azacitidine, for example, move to some form of maintenance program later on. That is about ABT-199. It's being explored in AML, soon in ALL, and in CLL, among others. We had the vosaroxin, which is a topo inhibitor. There was a randomized study presented last year at the ASH by Farhat Ravandi, where patients in relapse setting were randomized to either high-dose RSC versus high-dose RSC and vosaroxin. The primary endpoint was not met, although as a preset design, patients who did not go for transplantation, who are elderly, most of them, did have a survival improvement. The drug is not approved. It may get an approval in Europe. But we're using this drug for MPN MDS patients, transforming into AML unfit for chemotherapy in combination with decitabine. There was a presentation at the ASH meeting combining decitabine and vosaroxin. The drug can cause severe mucositis, can have some complication. At the lower dose, 70 milligram per meter square is better than the higher dose. Still unknown whether it's better than decitabine alone or not. You know, when you do the phase 2, you get so excited. You go for a phase 3 study, you get disappointed. Also, sometimes you can have 10 days improvement or a month's improvement, not enough in leukemia, but in pancreatic cancer, it can get you a Nobel Prize.
Sure.
Other interesting compounds being presented at the ASH meeting, IDH2 inhibitor, IDH1, IDH2.
Absolutely.
They're being used as single agent in these patients, although the allele level doesn't change with therapy, but they go into response, late responses. Single agent monotherapy, I don't think it's enough, but at least we have a good signal to go for a combination and hopefully later on a randomized trial. The sorafenib FLT3 inhibitors are a family present to stay. We're using sorafenib off-label because it's not approved for AML, but no, we will have the first drug hopefully approved as a FLT3 inhibitors. We had the Mylotarg in the past. We have a new antibodies, different than the Mylotarg being assessed for CD33 expression. Ravi mentioned the CD123 as well, antibody by Johnson & Johnson and others. They have drugs as well, monoclonals being assessed, spliazone modulators as well. We have a plethora of drugs. The idea is, as Rafael mentioned, let's have the good personalized medicine. Let's use the drug where really we can induce a response, because it's blindly on to everybody. Then you dilute your results and nobody knows what's going on.
So you raise, I mean, there's a whole different, avenues of investigation, which really are quite exciting. As I was looking at the breakdown of the different oral sessions for therapy for AML, of which there are multiple, They're even themselves kind of broken into different groups. Now, one potential avenue is being discussed in another plenary abstract by Omar Abdelwahab's a group from Memorial around the spliceosome and whether that can be leveraged or targeted some way in myeloid mutations. Ralph, why don't you walk us through a little bit in terms of the spliceosome and you know, a little bit about how those observations may be something we might be able to leverage in the future.
So what people discovered clinically was that these splicing factors are often mutated in myeloid malignancies, and including some cases of AML as well. What we know is that these splicing factor mutations only affect one gene. We never really see two splicing factor genes mutated together. And one of the reasons that might be is because these two hits aren't tolerated. It suggests that further disruption of the spliceosome might actually not be something that the cells can tolerate. It might cause cell death. So in the abstract that you mentioned, the investigators generated a mouse model where the mouse carries the mutation that we see in patients and then treated those mice with an inhibitor of the spliceosome. And what they found was that the cells that carry that mutation were selectively sensitive to that agent, whereas the normal hematopoietic cells that don't have any pre-existing abnormalities of the spliceosome could tolerate the treatment. So we may actually have a therapeutic window to treat with a splicing inhibitor, a type of drug that we typically don't think of as an anti-neoplastic or a cancer drug.